I want to follow up on that, and then I'm going to ask one follow-up question. Then I want to bring Dr. Murillo in to talk about some of the pharmacoeconomics as well. But both Steve and Dr. Desai, you're both well-known researchers, progressive in the field, et cetera. Do you feel like the SGLT2 inhibitors becoming standard of care has become pervasive throughout the cardiology or CHF treating community? And if not, what's holding it back? I mean, it sounds as if we have all evaluated the data in the same way, provider, moderator, and payer. What's holding it back from becoming more prevalent?
I'll comment first, if I may. We have a lot of trouble getting payers to pay for these drugs. I mean, the burdens and, the barriers are very high, and making the case has been very difficult. And I've met many patients with diabetes, reduced renal function, some element of heart failure, where it's pretty clear that the benefits are impressive, and I just can't get them on the drugs. And, I've had actually patients who have some economic means getting the drugs from Canada, which I don't approve of. But I've had them doing that because they just simply can't get them paid for. And so it's really a concern.
Yeah, I want to echo that point, that Steve made around, access. I think that's an important area for all of us to sort of advocate, to say, hey, evidence should be connected to coverage and ultimately to access. And I think that is an area where we can certainly do better. I also think that there are some, sort of historical silos that we need to break down between cardiologists and endocrinologists, or cardiologists and, sort of primary care providers, and who sort of has jurisdiction, if you will, over, prescribing a certain kind of therapy or a certain class of therapies. And I think the patients deserve a lot better than that. And I think what they want is to know that everyone who's caring for them, regardless of specialty or background, is thinking about optimizing their care at every opportunity. And I think for that, it's on all of us as, clinicians and members of the community to sort of come together, engage with our colleagues, reimagine and rethink what care should be for these patients, and to try and abandon some of the historical silos that have, I think, impeded progress in terms of adoption and implementation of this evidence in practice.
Nihar, you make an incredibly important point. This siloization of care is a really big problem. Diabetes and heart disease are overlap syndromes. And so we have the diabetologist often who's writing the prescriptions. We have the cardiologist who's treating the complications of the disorder, and they're not always talking to each other. And we almost need a new specialty of, cardiometabolic health. We recognize that, and we hired recently in my section of preventive cardiology here, someone who's trained in both cardiology and endocrinology. And he now sees patients in the prevention clinic at the Cleveland Clinic. And I think that is an important discipline for the future. Now, not a lot of people are willing to go through fellowships in both disciplines. So what we have to do is talk to each other and work together, because these patients are not do not belong to one specialty. They belong to multiple specialties. And I might add, the nephrologists also have to have a seat at the table, given the morbidity and mortality from chronic renal disease.
And so I'm going to ask Dr. Murillo, because I keep saying I'm going to get to him, and we keep coming back around. So, there have been some discussions here about there are barriers to the usage. Some of those barriers may be access or are access related to payment and reimbursement or coverage. Some of them are the siloization and some of the other things we talked about. Is your organization getting a lot of requests to use SGLTs in non-diabetic patients and in earlier stages of heart failure?
Yeah, I think the key word they used was non-diabetics. So as I mentioned to you, those medications are are part of the armamentarium. I mentioned to you, we spent so far more than $100 million in that category alone. For the non-diabetic, I think that's where we still have an opportunity. And I was mentioning to you, I was reviewing the agenda for our next meeting in July. So there's a fair amount of information because it's not been approved yet that I have to keep the details out. But the bottom line is that's the direction we're moving toward.
And will changes in the indication or changes in the labels affect coverage, not just for you, but overall? Is that something that you would anticipate? And then I'll ask if the prescribers think that would make a difference as well.
Yeah, well, that's it's a great question. So far, I can say that when you pull the different studies and you get about 38,000 patients close to it, the benefits are essentially across the board, and we're treating this as a class. We're not taking this as one single medication does this and the other SGLT2 does this and so on. So we're treating them as a class effect.
Okay. Others?
Yeah, I mean, I think so far what we've seen is that the effects do represent a class effect. And, you know, I mentioned earlier, and I'll just say it briefly again, that it's nice to have replication. We like to see replication. So I'm going to be very eagerly awaiting Emperor HF, particularly in the preserved EF group. Now, that's a big reach. It would be extraordinarily exciting for cardiologists to have a drug for HF. You know, and you know, I don't know what's going to happen. I can't predict it, but seeing replication in HFrEF will make me convinced that it is a class effect for sure.